Hi, welcome. My name's Amy Vaughn. I'm a doctoral candidate for the University of the Cumberlands. Today, I'd like to talk to you about prolonged exposure and cognitive processing therapy for PTSD in veterans and active duty military. So, what we see with the veteran and PTSD statistics is that there are about 18.5 million veterans living in the US as of 2017. An important thing to recognize when we look at the PTSD statistics are we look at about 14% of Operation Iraqi Freedom and Operation Enduring Freedom, the more recent wars. Veterans have PTSD within their lifetimes. 12% of Gulf War veterans and 30% of Vietnam veterans. Now, these numbers are quite a bit higher than the nationally representative average of the civilian population, of whom only have about 7% rate of PTSD within their lifetimes. So these numbers help solidify the value and need of effective PTSD treatments for the veteran population. The PTSD is a psychiatric disorder that can occur in people who have experienced or witnessed a traumatic event such as natural disaster, a serious accident, a terrorist attack, war, combat, rape, or other personal violent assault. These situations in wartime can include being attacked, whether it be physically, personally, whether somebody is actually assaulted by another individual, being shot at, having a vehicle blown up, could be actually being a person who engages in and shoots at other people. It could be witnessing a fellow service member being harmed, or even a civilian casualty. It can be medical professionals who walk up upon scenes of casualties or where people have experienced harm. But basically, in these situations, a person has experienced a traumatic event or believed that their life was in danger. And people with PTSD continue to have intense, disturbing thoughts and feelings related to that traumatic experience that last long after the traumatic event has ended. So we're looking at least a month or longer. And it causes significant impairment to life, social, work, family situations. They may relive the event through flashbacks or nightmares. People with PTSD may avoid situations or people that remind them of the traumatic event. And they may have strong negative reactions to something as ordinary as a loud noise, an accidental touch. They might be a little more on edge, jumpy, irritable, difficulty falling asleep, might avoid situations where they have to be around crowds, engage in checking behaviors, and so on. So there are a lot of treatment options available for PTSD. Two of the more frequently used treatments are cognitive processing therapy, CPT, and prolonged exposure, PE. Due to being evidence-based, they've been around for a while, they've been used, and they have good empirical validation. Other treatments that are available and have been effective in treating PTSD are eye movement desensitization and reprocessing, EMDR. That one is frequently used and often cited, just hasn't been quite around as long as CPT and PE, but there's a lot of good evidence for it. Brief eclectic psychotherapy, narrative exposure therapy, written narrative exposure, and specific cognitive behavioral therapies. Also, medication management is often used either independently or in conjunction with some of these. For the purposes of this presentation, we're going to focus on CPT and prolonged exposure. So cognitive processing therapy is based on the social cognitive model. And so we're looking at any kind of distortions in the cognitions and how those affect the behavior. So CPT was originally created to treat rape victims, but a manual has been created specifically to meet the needs of veterans. And we want to address faulty cognitions and challenge them to accommodate the memories and beliefs. We see a standard is around 12 sessions that are 60 to 90 minutes in length. It's the preferred to be able to do this twice a week. Now, 60 to 90 minutes may seem like a long time, but the sessions are actually relatively planned out and have specific focus for each one, which is why it's important to stay on task. It's also important to ensure that the veteran and clinician agree that this is the best format, because there's little room for tangents or work outside of the specific topics. And additionally, if we're going outside of the specific topics, it can be a bit of an avoidance strategy at times, and so that needs to be addressed. This is a large commitment, so it's important to make sure that the veteran is ready and able to make that kind of time commitment. There are 4 components to this treatment: psychoeducation, learning about PTSD, how it affects cognitions and emotions and physical; understanding the relationship between thoughts and feelings; developing the ability to identify and challenge cognitive distortions; and learning to accommodate the trauma experiences. So I'm going to go over the bullet 3 and 4 just a little bit more. The usual format for the sessions is to begin with a review of the practice assignments or homework, followed by the content of each specific session. So again, it's manualized. You're going to know what you're going to be working on for each session. And during the last 15 minutes of the session, the assignment or homework for the following week is introduced and is accompanied with an explanation of how to complete the assignments. One major component of the cognitive processing therapy is stuck points. And this is the identification of maladaptive beliefs that prevent recovery. Some examples of a stuck point would be bad things happen to bad people. So this belief would then, we might interpret the situation as something bad happened to me, therefore I must be bad or I must deserve something bad. Beliefs that you are to blame for what happened, therefore, or the world is an unsafe place. We want to be able to identify these maladaptive beliefs and look at how those are impacting the veteran and preventing the recovery so we can eventually work towards challenging them. We use Socratic questioning as we process the very worst trauma, so we get them to identify what is the very worst, and then use the Socratic questioning to begin challenging these distorted cognitions, particularly those that are associated with assimilation, like self-blame, hindsight bias, and other guilt cognitions. We teach the veterans skills to challenge their own thoughts and develop new interpretations, so a skill that can go above and beyond the sessions they have here, but long after the therapy. And then a written narrative may or may not be used depending on the clinician and the client, where they would write out their trauma narrative. Use skills to address other areas of the veteran's life. So there are, after we learn these skills of challenging the thoughts and developing new interpretations, we look at other areas of life where some of these beliefs have impacted functioning. Might be related to safety, power, feelings of control, esteem, and intimacy issues, and address all of those as needed. Homework is a key component of this treatment. You may not use the word homework. It could be assignment or continued work. If the homework is not completed in session, then typically it will be brought back and they will complete the assignment in the session and process that, and will continue to be assigned these homework assignments at each session. Prolonged exposure takes a little bit different of a direction. It's developed by Edna Foa, and it's based out of emotional processing theory. It's designed to help clients approach feared or avoided thoughts and memories, as well as situations or triggers. So we're looking at using extinction process. It is also a bit lengthy, 12 sessions that are 90 minutes in length. So it's also important to make sure that the client can commit to this length of a process. Again, this is also, when in nature of sharing a trauma, you must have a strong therapeutic alliance before engaging in this kind of work. This treatment also has 4 components. Again, psychoeducation. We do some breathing retraining, so helping learn a little bit more physical regulation, imaginal exposure, and in vivo exposure. So we're going to talk a little bit more about bullets 3 and 4 in this particular presentation. So imaginal exposure is about 30 to 45 minutes of the session is devoted to revisiting and processing the trauma narrative. The veteran may also be asked to listen to recordings or read a narrative that the veteran made at home as well. And it works to diminish the fear response through extinction by continuous exposure to this narrative and being able to regulate the body during this time, that the veteran will experience less and less anxiety or whatever the negative experiences are that the veteran typically has when these trauma memories are brought up. The client and the veteran collaboratively process the experience to allow the client to process and modify any beliefs if necessary. Interesting thing is virtual reality exposure is now an option for some particular therapists who have that technology. In vivo exposure, we ask them to create a hierarchy of avoidance. So a list of avoided situations or places due to trauma will be created, and we'll ask them to rate them from a low perceived risk to the highest perceived risks. And we're going to start with those lower risk situations to be addressed first. They conduct homework outside of the session to approach lower level avoided situations and build from there. So an example might be perhaps going to a grocery store might be an avoided task due to large crowds and unpredictable situations. You might ask them to just go sit in the parking lot or go to a smaller drugstore during low use hours or bring a support person, and then slowly work towards being able to get to that larger target goal of going into Walmart. But with practice, the anxiety will decrease and the veteran realizes this situation is safe and they are unharmed. The advantages of using CPT and PE is that it works. They are the most evidence-based, empirically validated treatments for PTSD within the civilian and military populations. We're looking at about a third of veterans seeing improvement and no longer meeting PTSD diagnosis criteria. It's manualized and structured, so it's easy to use, it's consistent, and it can be used, both can be used individually, and CPT has the ability to be used in a group setting as well. Potential drawbacks are the length of the session. They're a little bit longer than the average session, so it's a pretty significant time commitment for active duty or veterans. If you have work to get back to, it can be a lot. The ability to complete homework while balancing work and family. So people have a lot of commitments, and so to be able to do these assignments, whether it be the written assignments or practice going out into the world and trying new things, can be an additional thing on top of all the things they're already doing. And it does cause distress. We're asking people to re-experience, relive, to talk about these things, and so it can cause distress within that individual. Some reasons that clinicians avoid using them is they may think that they might re-traumatize the veteran by asking them to relive an experience. Is going to cause them undue stress. Now, we do know, yes, it is going to cause them distress. However, the memories are already there. The client's already reliving the experience, so we're not going to traumatize them more than they already are. Over-engagement, the client is going to freak out and run out of the session and never return. While this is possible, it is more likely you're going to experience under-engagement where the client needs a little more encouragement to do the work, to do the processing. It is important to remember that training is required to engage in any of these treatment modalities. If the clinician doesn't set up the hierarchy correctly, it could put the client in a situation that they're not prepared for. And so we want to make sure that we create a safe environment and that we also set the clients up for success. You can't just pick and choose the parts of the treatment for use. It is empirically validated to be used just the way that it is. A clinician could start treatment before the client's ready to process the treatment or the intervention's not a good fit. You need to do a full assessment with your client to make sure, one, that they're ready to deal with this trauma, that they're in a good place. If they're suicidal, might not be a good time to deal with this intervention. We might want to stabilize first. And also that the client is at a good point in their life where they're ready to deal with this, that they're ready to engage in treatment, that they understand all of the components involved in engaging in this type of intervention. Here are some references if you are interested. I thank you for participating, and please enjoy the rest of the survey.